Oh, I think HIV therapy is an enormous success story. When you think that in 1981, I was telling all the patients they would die, but we'd try and make sure that was with dignity and without any pain. And we're now telling people you will all survive long term, providing you take some pills. That's a miracle, really.
Patients today going on antiretroviral therapy onto HIV drugs, there's a fantastic prognosis for them. I would say to them, look, I don't think HIV itself is going to cause a serious limitation on your life expectancy. So take your pills every day, get the virus under control, and go and live the life that you've always dreamt of living.
Nowadays, HIV is a very treatable infection. We have a wide range of agents which we can utilize to treat individuals. And perhaps more importantly, we've learnt how to use them appropriately.
Of course, people do sometimes fail when they're actually taking treatment. Undoubtedly, very much the commonest reason for that is they don't adhere properly to their medication.
Not everyone who takes antiretroviral therapy ends up with an undetectable viral load for a long period of time and go on and have what we would call a normal life. Some of them, for one reason or another, and it's mainly around not being able to take the pills, end up with resistant virus where we then have to move on to second-line therapy.
The first thing we need to think about when we see an individual where therapy is failing is why are they failing? And there may be several reasons. The reason people are failing therapy is normally because of toxicities. Those toxicities are driving non-adherence, i.e. patients won't take treatments which make them feel unwell. And then what happens is the virus starts to reproduce. It's reproducing in the presence of the drugs which are trying to stop it reproducing. And then the virus changes. It makes changes in its genetic structure, which then lead to the drugs not working. We then need to see what drugs we may want to utilize in the future, which drugs will work, and how do we choose there? Well, in this country, what we do is a resistance test that's looking at the genetic makeup of the virus and how that virus has changed and how those changes will influence the potency, the power of alternative drugs in combination which we can use.
To resuppress the virus in somebody where their virus load is raised, we use resistance tests. I think all of us use standard genotypic testing as the first line of deciding whether resistance has occurred. Resistance testing is taking a very small sample of a very large virus pool and hoping that that is representative of the overall pool. And of course, sometimes it's not. And so if there is within the pool minor variants which are resistant to the drug, these could become the predominant resistant variety if you then give the wrong drug combination.
So in a resource-poor setting, things are rather different. First of all, we have less availability of drugs. Secondly, we can't monitor how well those drugs are working as well. And that means that we're likely to see much more resistance, changes in the viral genome at the time that resistance is identified. And because we have fewer agents, we have less goes at getting it right. So it's essential when we see patients who are virologically failing that we choose the best regimen to get them undetectable or virologically undetectable in the future.
So in resource-limited settings, the major challenges are, of course, lack of money and a very, very large epidemic. So to deal with that, we need to rethink, one, how we medicalize the giving of drugs, and perhaps we should demedicalize it. Secondly, how we provide accurate tests at the bedside so that the person needn't travel to and from continuously, but we are certain whether or not the present treatment is working. And thirdly, of course, the whole panoply of treatments are just not available in some developing countries.
In areas where resistance testing is not available or not widely available, unfortunately, the choice of agents is often done on a best guess. That just leads to higher rates of virological failure, more resistant virus in the community. So that's bad not only for the individual, it's also bad for the population as a whole.
The strategy in the developing world at the moment is ever-changing. But I think the first thing to say is that one of the things that we perhaps should be doing is a much more test and treat policy. That at the moment, you have an HIV test, and you then have a CD4 count, you have to come for the result, you're very often told to wait several years, and the rate of non-attendance, because of transport costs, etc., is very high. So one of the things that we could do to really change that would be to say, you're HIV positive, you should be treated. The second approach, of course, as we've discussed already, would be to make bedside testing both cheap and feasible. And what RDI and other people are trying to do, of course, is making such testing cheaper, more reliable, and more robust, of course.